Welcome back to the next edition of Dr. Twyman's Ask Me Anything. If you want healthy arteries, this is where we're going to talk about them. So, got some great questions to answer for you guys tonight. So, we'll get started here. So, the first question up tonight is, if I could pick one test to check for your heart health, what would it be? That's a hard question. You know, it would depend on, I guess, your age, but if I could only pick one test, I'd probably pick the EndoPAT test. I'd want to know how healthy is your endothelium, because endothelial damage is the first thing that happens before you develop a plaque in your arteries. So endothelial dysfunction can happen in your teens or 20s. If you have endothelial dysfunction, you're set up to develop plaque many years down the road. If you already have plaque in your arteries, or if you already had a heart attack, stroke, or stents, bypass surgery, you need to develop healthy endothelium not to have it happen again. So EndoPAT test is probably my number one test to look at. Now, if you can do more than one test, probably want to do some tests that actually looks for, plaque in the arteries. So either a CIMT scan, calcium score, or a CT angiogram, preferably with the AI algorithm. Next question up tonight. Looks like 84-year-old on 2 atrial fibrillation medicines, 2 weeks after an ER visit for an infection in the gallbladder, attack many years ago. Can I get off meds, or is it risky? So I can't answer this question. I cannot give individual medical advice through this forum. So you have to ask your doctor who put you on the medications, is it safe enough for you to come off of it? But in a generality on atrial fibrillation, there's 2 things to consider. There is the control of either the rate or the rhythm, and then there's the stroke risk of atrial fibrillation. So the rate or rhythm control, that can be either beta blockers, calcium channel blockers to prevent the atrial fibrillation going fast when you're in AFib, or some patients are on antiarrhythmics to try to keep them in sinus rhythm. Depends on how symptomatic you are, if you need to be on those medications long term. Those ones aren't as concerning, but it's the stroke risk one. If you're on anticoagulation, one of the, Eliquis's, Xareltos, or the old school warfarin to reduce your risk of stroke. If you stop those medicines, your risk goes back up to your baseline. There's a score known as the CHADS-VASc score. The higher that score, the more likely you are to have a stroke. So age is one of those risk factors that you can't do anything about. So you're going to get at least 1 point for your age there. So you need to talk to your own doctors about, what is the risk of continuing the medications. But if you have a proximal cause but caused atrial fibrillation, you may not necessarily need the rate controlling agents or the antiarrhythmics. All right. What additional recommendations do I typically make for somebody with very high LPLA? This is a great question. I get it often. I've been looking at LPLA since at least 2013. I know it's now getting more popular because there's finally drugs that are about to hit the market to actually lower LPLA. In the interim, you basically just have to try to lower all the other risk factors that you can, because there's about 300 to 400 different reactions that can damage the blood vessels. So with LPLA, I will always look at a lab called LPPLA2 activity. If that enzyme is elevated, that is being carried around by LPLA, then it's much more likely arteries are being damaged by LPA. There's more likely there's inflammation in the arteries. If you have high oxidized phospholipid ApoB, that is also cargo that the LPA is carrying. There's a newer lab that I've started looking at called interleukin 6. It's available on the Boston Heart Lab panel. If IL-6 is high, essentially your lining of your arteries is inflamed, but high IL-6 will raise up LPLA. So if you have a lot of inflammation, work on trying to lower the inflammation. Switching up to a quantum biology question. What are my thoughts on the magnetic of sleep pad? I must have been reading my mind because I was actually searching for it yesterday. I've known about it for many years, just haven't pulled the trigger on it. It's a investment for sure. It's a couple $1,000s to get the biggest ones, the 20 gauss pads, and they're no joke heavy. I mean, they're 300 to 400 pounds to put under your bed. So you got to make sure you have a frame that can support that, and that your topper mattress is not too thick. So the magnetical sleep pad helps with recovery essentially of your mitochondria. While you're sleeping, that's when your body's repairing itself. Higher magnetic fields are associated with nighttime. During the day, the sun is knocking down the magnetic fields on the earth that you sense, And now with so much EMF pollution, the body gets confused, is it daytime or nighttime? Having a strong magnet to sleep on, basically tells your body it is absolutely nighttime. So when you sleep on this magnet, the electrons are being, basically pulled faster through your mitochondria. So you're making more ATP, water. So it is interesting. The only downside is, literally the cost of these things and the weight. And you also cannot have a pacemaker, defibrillator, any type of electronic devices in plantable devices that cannot be near magnetic fields with these things. Does Ezetimibe monotherapy provide benefits in reducing risk of cardiovascular events? Yes, it's just not as potent as statins and PCSK9 inhibitors. So the 4 classes of medications that affect lipoproteins that do have outcome data at reducing MACE, major adverse cardiovascular events, are going to be the statins, Ezetimibe, that was shown mostly in the IMPROVE trial, which was add-on therapy to a statin, the PCSK9 inhibitors, which are mainly Repatha, Ilisclerine, also Praluent, and then the new kid on the block, bempedoic acid, which only has a brand name at this time called Nexletol. But great medication for people who are statin intolerant or just elect not to start statins. Ezetimibe's a good second choice for many people because it's oral, generic, and been on the market for over 20 years and very minimal side effect profile. Seems to be a genetic question. Looks like somebody can't tell if this is okay. 2 different patients, but one has a mutation for MTHFR A1298C, and one has a mutation for 677 mutation. What are the risk and treatments? The 677s tend to have more issues, but number one, it's a marker of you need more sunlight, essentially, when you have these mutations. And secondary, you can be looking at different biomarkers. The one I would look at would be homocysteine. If your homocysteine is over 8, you may have issues with these methylation defects. In those cases, then you're using methylated, tetrahydrofolate, methylcobalamin to help convert the homocysteine back into methionine. So looking at homocysteine levels, you can also look at oxidized LDL, oxidized phospholipid ApoB to see if you have issues that you need to be on more methylated B complexes. Alrighty, next question rolling up. Is it possible to get off statins after 17 years after having 3 stents, diabetes, and hearing loss? Again, can't answer directly for somebody. You have to talk to your doctor who put you on these things. But the goal is to keep your arteries healthy enough that you don't have further events, no further stents, no bypass surgery, no strokes, no heart attacks. So statins are one of those tools. Not everybody tolerates them. So that would be the question is, why would you like to come off it? Are you having side effects that need to be, adjusted and maybe change to something else? That's a different story. But you're going to want to look at what is your ApoB goal. With that kind of story, ApoB goal is probably at least less than 70, maybe even 55. So you're probably going to have to replace the statin with something else. Because if you just come off of it kind of cold turkey, unless you made dramatic changes in your lifestyle, your lipoproteins are going to go right back up to your baseline where they were 17 years ago before you started the statin. All right, we got 2 more pre-submitted questions, and then I'll answer the things that are popping up in the comments. Can you get full spectrum light sitting on a screened porch? It's going to depend. If it's literally a screen porch where light gets through the screen, then yes, you can. But if it's some type of glass or plastic, then no, it's not. It's going to filter some of that out. Now, I would say that you should still try to get more light on your skin, kind of, in the midday for at least 10-15 minutes, because you're not going to be making optimal vitamin D through a screen porch. But after you've kind of gotten your full fill of full spectrum light, then retreating to the porch is not a bad idea. All right. And then last pre-submitted question. Does fluoride have an effect on the heart and arteries? Indirectly, yes. Fluoride will disrupt the oral microbiome. If you disrupt the oral microbiome, you may not be able to make it very much salivary nitric oxide. Fluoride can affect the thyroid. Fluoride can affect the brain. It is a neurotoxin at certain levels. It affects the mitochondria's ability to make water. So if you can't make water in your mitochondria, you can't make energy efficiently. If you can't make energy efficiently, your mitochondria aren't working well, and your heart is approximately 1/3 mitochondria. So you do want to avoid fluoride in your drinking water and likely in your toothpaste as well. That's why if you're one of my patients, that's what the question is in the questionnaire about what type of water you drink. It's not that I'm taking recommendations. I personally just like Mountain Valley spring water, but if you're drinking tap water, many places are adding fluoride to the tap water. You're going to want to use a reverse osmosis filter or a Berkey filter or some other high quality filter to strip the fluoride out of the drinking water, because that's your biggest source of fluoride exposure for most people. All right. So those are the live questions. Like I said, I'll answer the comments in a moment. Welcome everybody who's joining. I want to give you guys an update that it will be August 2nd. Apollo Cardiology, my practice in St. Louis, Missouri, is having a birthday party essentially. We had one last year in my office. If you were there, you know what you know. It was super hot. The AC in the building broke, but thank you for those that came out. This year, outside, it's at the park. It's at Shaw Park here in St. Louis. It'll be from 4 p.m. to 8 p.m. Friday, August 2nd at the Enterprise Pavilion. Please RSVP to this so we can make sure that we got all the right head count and can get the right amount of food and beverages for people. Will be provided. And there's going to be some very excellent door prizes that my team is putting together. And if you're there live, that's where I will tell you what the grand prize is going to be. And I promise you, you will not be disappointed in the grand prize. But back to the questions. All right. It's kind of like those YouTube ads where they just pop in the middle of you watching a video. It's not an ad. It's for my own business. All right. All right. Question: what are my views on long-term use of statins? I've shared this often. I talk about it. Statins are tools. They're not supposed to be in the water for everybody. They're not poisons for everybody. If you have severe plaque in your arteries, prior events, statins are a tool that can reduce your risk of having that happen again. The question really comes into primary prevention. So, statins lower HMG co-reductase. You produce less cholesterol in the liver. You make less lipoproteins. The number one side effect of statins are muscle symptoms, muscle pain, weakness. I personally have never seen a case of rhabdomyolysis where the muscle breaks down from statins. But patients who tend to have more issues with statins tend to be vitamin D deficient. They're underactive on their thyroid, so they're hypothyroid. They're low CoQ10. They're often an ApoE4 carrier, which is genetically tested. And then there's a gene called SLC01B1. If you have that gene, statins are more likely to cause you muscle symptoms. So potentially don't use that as first line. Mainly, I'm looking at ApoB targets. The tool to get them down there is less important to me. Statins have just a long track record of being relatively safe. Again, not everybody can tolerate them, but they are relatively safe. And they are relatively affordable. Statins are generic and have been for many years. When I was in my initial training, there wasn't very many generic statins, and they're very expensive, and it's hard to get a hold of them. Ezetimibe is also generic. The other, pharmaceutical treatments, if insurance doesn't cover them, they're generally $500 per month. So that's why sometimes you got to kind of talk to the patient. What are your goals? What is your budget? If statins are absolutely off the table because they have side effects, we'll find another option for them. But if they can tolerate them, then we often leave them on it. But this is, an individual decision with the person who's sitting in front of you. Next question: what is a treatment for endothelial issues? First, find the root cause of what's damaging the endothelium. It's often oxidative stress and inflammation. You can look at different biomarkers to figure out what's driving that. But you need to focus on the basics, optimizing sleep, prioritizing sleep, getting 7.5 to 8 hours of sleep a night, getting proper sun exposure. When UVA light strikes your skin, nitric oxide is released. Previously answered the question about fluoride exposure. You don't want to disrupt the oral microbiome. So you want, when you're eating foods with nitrates, which are green leafy vegetables and beets, you need to have the right bacteria in your saliva to be able to break that stuff down into ultimately nitric oxide promoting compounds. So Exercise is also very good for it, as blood is flowing across the glycocalyx, nitric oxide will get released. And there are various supplements that can support it as well if you can't get it improved with drawing the things that are causing the root cause of the damage, and then doing the lifestyle things, exercise, sun exposure at the right time of day, and then green leafy vegetables if you can tolerate them. Question: a 24-year-old went into atrial fibrillation during sprints, had echo in the past, no issues. Any input advice on the scenario? Doctors at the ER had no clue what caused it and can't get in to see a cardiologist until October. So it does depend a little bit on how conditioned this person is. If this is a person who is more of a high endurance athlete, and this is something that they're doing a lot of exercise, I've seen not uncommonly. The left atria expands to improve the stroke volume for these kind of long distance runners, cyclists, and such. But atrial fibrillation, has many drivers. High oxidative stress and inflammation are some of the kind of low-hanging fruit ones you need to look for. Untreated sleep apnea, can be present in any age. So sleep apnea can drive it. Hyperthyroidism, overactive thyroid can drive it. So often a comprehensive blood work panel and kind of looking through kind of the echo to see like what size of the left atrial volumes are, the pulmonary pressures can give you an idea like, is this more likely to happen again? Question: is artificial blue light just as damaging to darker skinned people as it is to fair skinned people? I wouldn't know how to exactly quantify that part, but melanin is going to reflect some of that. So darker skinned people have more melanin, obviously, and artificial light, can be problematic, when it's not at the right time. So not all blue light is bad. Blue light from the sky is always balanced with other wavelengths of light. But it's when you're in front of these type of devices for 8-10 hours a day and you don't have a filter on the screen, or you're not protecting your eyes with blue blockers, that you can get yourself into trouble. So good question, but it's the ALAR principle. As low radiation is allowed, and it's the principle of like, if you don't have clear evidence on it, then don't do something that you don't know for sure is safe for you. So minimize blue light exposure when possible, artificial blue light exposure, especially at nighttime. I can't see if this is a 1.3 or 13. Looks like 1.3, but I don't know how there would be a point. I've never seen that. So it looks like, is a 1.3 fasting insulin good? I can't read that number if it says 1.3 or 13, but typically I like to see fasting insulins under 8. For insulin's greater than that fasting, it doesn't necessarily mean you have a major problem, but you need to look at some other markers. Do you have elevated small dense LDL? Do you have high triglycerides? Do you have high VLDL? Do you have an abnormal HOMO-IR score? Then okay, then maybe that insulin is a true marker of insulin resistance. Question: do I check the omega-3 index? Pretty much every patient, every single time, have for over 10 years. What is my goal? The omega-3 index, generally I believe, the cutoff is 5.5%. The reason I can't say for Shuntamed is that some of the lab companies have a little bit different cutoff, and I use a couple different ones. But my goal is to also have a balanced omega-3 and omega-6 ratio. So if you're doing the omega-3 over omega-6 ratio, it should be 0.25. If it's the omega-6 over omega-3 ratio, it should be 4:1. Can high cholesterol and or heart valve regurgitation cause palpitations? So I answer the first part. So cholesterol should have nothing to do with your palpitations, but heart valve regurgitation definitely could contribute to palpitations, particularly if it's mitral regurgitation. So an echocardiogram would quantify the degree of regurgitation. Is it trace, mild, moderate, or severe? And then we'll look at the chamber sizes. Are they dilated? The more your left atrial volume is increased, the more kind of the wiring system's getting stretched out, and more likely you could have palpitations. How do I test for microvascular angina if all standard testing are normal? That's a very good question. Hopefully in the next year or two we'll have a better screening technique. There's a magnetocardiography, or MCG. It uses non-radiation sources, 90-second test to look at the magnetic fields coming off the heart, and can pretty much tell you, do you have microvascular disease pretty quickly. I've done the test on myself, screening about a year ago. Very interesting technology. They're working on some FDA clearance on it right now. So when that comes out, that'll probably become the standard of care. But until that point, we got to kind of look at some other factors. Microvascular angina, well, 99% of your blood vessels, they're smaller than a human hair. So you have to look at what's potentially breaking nitric oxide and do the testing for that. So that's what we do at Apollo Cardiology, is we test for nitric oxide. So we test for salivary nitric oxide. We test for downstream effects of nitric oxide, so arterial elasticity. We use the max pulse device to look at that, so how stiff are the arteries. We look at the blood pressure. We look at brachial blood pressure, which is the blood pressure in your arms. And we look at the blood pressures as it comes out of your heart. That's known as your central aortic blood pressure. That pressure should be less than 120/80. We look at the EndoPAT test, which I talked about at the top of the hour. That tells us how much nitric oxide the arteries can release when there's a stressor to the arteries, and the arteries should triple to quadruple in size when there's a stressor to the arteries. And then there are the different biomarkers you can look at. Urine microalbumin creatinine ratio is a good marker that if it's high, you often have glycocalyx destruction. If you break the glycocalyx, you're going to damage endothelium. If you have high uric acid, it will damage the glycocalyx. You'll have lower nitric oxide. Talked about earlier with the MTHFR question. If you have high homocysteine can drive a compound called ADMA, asymmetric dimethylarginine. And if that compound's high, it lowers nitric oxide, arteries get stiff. So we first figure out, okay, what's driving it, and then work on trying to support it. And there's various supplements and medications that potentially can help depending on how bad the microvascular angina is. Very good question. What is the best arm to measure blood pressure? The short answer is the arm that has the highest blood pressure. So there sometimes is a differential in the blood pressures. So first off, you want to take your blood pressure correctly. You want to be in a seated position with your feet flat on the ground. You want your back supported in a chair. You would like to have your arm at heart level, ideally resting on a table. And then you would have a brachial blood pressure cuff, one that goes over your bicep. You do not want to have ones that are on your wrist. They are generally very inaccurate unless you've had it calibrated against a machine at an office and it shows that it's sensitive. And then you would monitor on both arms. And whatever arm is higher, that's the arm that you should continue with. If you have greater than a 20-point delta or difference between your blood pressure, for example, if your right arm is 140 millimeters over 80 millimeters of mercury and your left arm is 120 millimeters over 80 millimeters of mercury, you're going to go with the one that's 140. But when there's a 20-point difference, it's generally one of two things. The person either has subclavian stenosis, they have a blockage in their artery going to their arm, and they're going to have a falsely low blood pressure to one arm, or they have an issue with the smooth muscle in the artery being constricted. There's a nerve issue. The nerve is, basically stuck in fight or flight response, and it's constricting the artery. So sometimes people have a pinched nerve in their neck, or they have some other issue with their brachial plexus. They have something that's going on with the nervous system to that arm. But check in the arm that is the highest. Is there a way to cure valve regurgitation naturally? The short answer is probably not. I usually would tell patients, your valves, when they wear out or they become stenotic, it's a wear and tear. It's a mechanical problem, and often it's going to need a mechanical fix. So it just depends on how symptomatic the person is and how much regurgitation there is. But some people can live their entire life with mild regurgitation and not have any symptoms and never need a procedure on their valve. When do I think medication to target LPA will be available? The phase 3 trials are wrapping up currently, if they haven't already, and should be this year. The only challenge with these medications are that they're testing them in high-risk individuals, people who've had prior cardiovascular events. So that's what the insurance companies are likely only going to cover these medications for. If patients are for primary prevention, meaning they've never had an event, no heart attacks, strokes, stents, bypass, and they just have high LPA, the insurance companies are not likely to cover these medications. It's much like when the PCSK9 inhibitors came on the market, 10 plus years ago or so. is that we'll only cover the people with the highest risk first. So it may be quite a while before it's widely available for everybody for LPA. That people will be able to buy it, much like they're able to buy Repatha or Praluent out of pocket, but I would suspect, and I have no insider knowledge on this, I'm sure they'll price it similarly, and it's probably going to be about $500 a month if insurance doesn't cover it. All right. It looks like I got through all the comments, so I appreciate the questions tonight. Some very good, preventive cardiology questions, some very good blood pressure questions, some very good lipid questions, and then some quantabology ones. Always appreciate it. Always like to kind of dip my toe into the quantabology world as well. I really think that's where the future is at. It's just that not everybody's on board with it just yet, so I don't go as deep in there sometimes. But it's really about keeping healthy arteries, stay healthy enough so that the breakthroughs in medicine come out so that you get the continued health span and longevity that you want. But if you don't focus on your arteries, that's the low-hanging fruit. The body needs healthy arteries to have healthy organs, and without healthy organs, you don't live very well. So appreciate your guys' time and attention. I'll be back next Monday, 6 p.m. Central Time. And if you're one of my patients or you're local to St. Louis, you don't necessarily have to be a patient of mine. The birthday party for biocardiology is again August 2nd at Shaw Park here in St. Louis. It'll be from 4 p.m. to 8 p.m. So I appreciate it. I'll see you guys next week.